Welcome to Bookfulness. This is a deep dive, episode 4. In the previous exploration, we began our study of the back, covering the fundamental structure of a typical vertebra, the basic blueprint, you could say, of the vertebral column.
Today, we move decisively beyond that typical pattern.
Yeah.
The fundamental reality of the back is that it must serve three incredibly different masters. It needs to house the delicate spinal cord, allow massive mobility, especially for the head, and, well, bear nearly all of the body's weight.
That's a huge challenge.
It is. And to achieve this, regional function dictates highly specialized characteristics. We're focusing specifically on pages 208 through 256 of our text today. It provides a fascinating roadmap of this specialization. Then we'll take an intensive look at the complex network of joints and ligaments that, anchor this crucial structure together.
I love that idea that the entire column is defined by this trade-off between mobility and stability. So if we start right at the top, the cervical region, that's built almost entirely for mobility, isn't it?
That's the primary design goal there, yeah.
Let's unpack the C3 through C7 vertebrae first. How do they immediately deviate from our typical blueprint we discussed last time?
Well, when you look at the typical cervical bodies, C3 through C7, the first thing that strikes you is probably their small size, especially compared to, say, the massive lumbars we'll get to later.
Right, they seem quite delicate.
But that size is sufficient because the lever arm of the head and neck is relatively short. It requires less sheer compressive strength up there. The bodies are also distinctly shaped. They're wider side to side than they are front to back.
And the articulating surfaces aren't just flat plates, which is kind of what I might have expected. They have those uncinate processes, giving them a unique shape.
Precisely. That's a key anatomical detail. The superior surface is concave, featuring these raised lips known as the uncus of the body, or uncinate processes.
Okay.
And the inferior surface is convex. So when one vertebra rests on another, this superior concavity and inferior convexity, they act almost like a male-female locking mechanism.
Ah, I see. So they fit together quite snugly.
Exactly. This system helps guide flexion and extension, but it also simultaneously limits lateral shear or translation. It's an early protective measure against horizontal slippage, which is critical in such a highly mobile region.
It sounds like a bit of built-in stability, even in this mobility-focused zone. But the really definitive feature, the hallmark of the cervical spine, has to be something completely absent elsewhere. The foramen transversarium. Those holes in the transverse process.
They absolutely define the cervical region. For C3 through C6, these foramina transmit the vertebral arteries.
Okay, the crucial blood supply to the brain.
Yes, these arteries are vital. They travel superiorly, join to form the basilar artery, and supply the majority of the posterior brain circulation. They're often accompanied by the vertebral veins and sympathetic plexuses too. It's an arrangement that maximizes protection for a major vessel by, well, surrounding it entirely with bone.
But I remember reading there's a critical exception to that vessel pathway C7. It has the foramen, but up.
That is one of the essential high-yield facts to remember, definitely. The C7 foramen transversarium is present, but it typically only transmits small accessory vertebral veins, not the main large vertebral artery.
So the main artery usually skips C7.
It usually enters the foramen starting at C6. So if you're analyzing an image or even palpating, knowing that C7 lacks the massive arterial traffic of C3, C6 is a crucial differentiator. C7 gets called the vertebra prominence for other reasons too, which we'll touch on.
Okay, let's discuss the transverse processes themselves, beyond just those foramina. They end in distinct anterior and posterior tubercles. What's the functional significance of those little tips?
Functionally, they are really important attachment points. They anchor the powerful laterally placed muscles that move and stabilize the neck. Think of the scalenes and the levator scapulae. And the space created between these two tubercles forms a protective deep groove. It's designed specifically to accommodate the anterior rami of the cervical spinal nerves as they exit.
Ah, protecting the nerves.
Yes. It ensures that the spinal nerves are sheltered as they pass out into the neck and eventually down to the upper limb.
And speaking of tubercles, there's a significant clinical landmark tied to C6, the carotid tubercle.
That's the anterior tubercle of the C6 vertebra, yes. It's named the carotid tubercle because of its immediate relationship to the common carotid artery, which runs just anterior to it.
So you can compress the artery against it.
In an emergency situation, yes. If there's severe bleeding from the carotid system, maybe from trauma, a practitioner can press the artery against that bony tubercle to mechanically compress it. Now, the complex network of surrounding vessels, the anastomosis, means the blood flow won't stop completely, but it provides a vital temporary maneuver to significantly reduce hemorrhage.
A critical first aid point. Now, looking posteriorly, let's address the shape of the spinous processes. Most are short, and many feature that famous split tipta, the bifid shape.
Yes, C3 through C6 are typically bifid. It's especially noticeable in male Caucasians, the text notes. This splitting at the tip provides additional surface area for the attachment of the deep intrinsic neck muscles.
More room for muscles to grab onto.
Exactly. The process starts lengthening at C6, but C7 is truly distinct. It has the longest, most easily identified spinous process in the cervical region. It projects almost horizontally.
Making it the vertebral prominence.
The vertebral prominence, correct. It's often the first easily palpable bony point when the head is flexed forward.
All right, we've covered the typical C3, C7, but the real magic of head movement relies on the true celebrities of the region. C1, the atlas, and C2, the axis. These are incredibly unique vertebrae designed purely for rotation and balance. Let's start with C1.
The atlas C1 is remarkable. It completely jettisoned the vertebral body and the spinous process. It favored torso support and mobility instead. It exists basically as a ring comprised of two massive lateral masses connected by an anterior arch and a posterior arch. The role of those lateral masses is purely load-bearing.
And what do those lateral masses articulate with? Upwards, towards the skull.
Superiorly, they articulate with the occipital condyles of the cranium. Those articular surfaces are large, kidney-shaped, and deeply concave.
Okay.
This is the atlanto-occipital joint. It's the mechanism for nodding the head. Yes, mostly a flexion-extension motion. This joint system is designed to stabilize the head on the spine while allowing that crucial up and down movement.
And even on the posterior arch, there's a dedicated groove for a critical vessel. I remember seeing that in the diagram.
Indeed. The posterior arch features a distinct groove across its superior surface. This is where the vertebral artery makes its final protected curve just before it pierces the atlanto-occipital membrane and enters the skull through the foramen magnum.
Ah, right before it goes into the skull.
Yes, and the C1 spinal nerve also runs within this protective groove. It's quite an elegant design, providing protection right up to the final entry point into the cranium.
So if C1 is the load bearer, then C2, the axis, must be the pivot.
Exactly. The axis, or C2, is actually regarded as the strongest of all the cervical vertebrae. Its defining feature is that blunt superior projection, the dens, or odontoid process.
Which is like a tooth, right? Odontoid means tooth-like.
Precisely.
Right.
And developmentally, this is essentially the migrated body of C1 that fused onto C2.
Fascinating. So explain the pivot mechanics. How do these two unique vertebrae combine to give us that massive range of rotation we need to shake our heads? No.
Well, the dens acts as a rigid central pole. The ring of the atlas, C1, which supports the cranium, then rotates around this pole. C2's superior articular facets are large and relatively flat, allowing the lateral masses of C1 to glide smoothly on top of them.
Okay, so C1 slides on C2 around the dens.
That's the motion. This arrangement forms the atlantoaxial joint, and it permits about 50% of the total rotation of the head and neck. It's hugely important. And critically, the dens is held tightly in place against the anterior arch of C1 by the strong transverse ligament of the atlas. This ligament prevents the dens from displacing posteriorly and potentially severing the spinal cord in cases of trauma.
A vital safety mechanism.
Absolutely key to understanding cervical injuries.
Okay, we've established the cervical region as the poster child for mobility. Now we move down to the thoracic vertebrae, T1 through T12. Here, the trade-off shifts dramatically towards stability and rigidity, largely thanks to the rib cage.
That is the perfect summary. The thoracic spine is intrinsically linked to the function of the rib cage. The primary characteristic that confirms you're looking at a thoracic vertebra is the presence of costal facets for articulation with the ribs.
Right, little smooth spots for the ribs.
Exactly. And the vertebral bodies themselves are distinctly heart-shaped, unlike the more rectangular or kidney-shaped ones elsewhere.
And they often feature demifacets, right? Meaning a rib head doesn't sit entirely on one body, but spans across two.
That's right, for many of them. Most typical thoracic vertebrae have two superior demifacets and two inferior demifacets, 4 in total. These articulate with the heads of two adjacent ribs and the intervening intervertebral disc. Plus, T1 through T10 also have facets on their transverse processes to articulate with the tubercle of the corresponding rib. This whole system essentially locks the thoracic spine into the rib cage, dramatically limiting overall mobility.
If we compare the vertebral foramen here to the cervical region, what do we notice? Is it bigger, smaller?
It's starkly different. In the thoracic region, the vertebral foramen is notably circular and also smaller than in either the cervical or lumbar regions. Our source, Moores, notes it admits only the distal part of a medium-sized index finger.
Wow, that's quite small.
It is. And this is a critical point.
Yeah.
Because the spinal cord occupies a larger proportion of the canal space here, it's particularly vulnerable to compression or injury during trauma or dislocation in the thoracic region.
And structurally, the thoracic spine is notorious for limiting certain types of movement. What specific elements dictate this rigidity, besides the ribs?
There are two main culprits, besides the rib cage attachment itself. First, the articular facets. They're oriented nearly vertically, extending sort of posterolaterally. This restricts movement primarily in the coronal plane side bending. Okay. Second, the spinous processes. They are long, they slope steeply downwards, and they overlap significantly, almost like roof shingles. This physical barrier severely limits extension bending backwards, and it also restricts lateral flexion and even forward flexion to some degree.
So very limited bending forwards, backwards, and sideways. But if stability is the goal, why does the thoracic spine permit the greatest degree of axial rotation compared to the other mobile segments? That seems counterintuitive given all that rigidity.
It does seem odd at first glance, but it's a direct consequence of the orientation of those articular facets. While their near vertical plane restricts sagittal and coronal movements, that same vertical plane actually allows for significant twisting or rotational motion between adjacent vertebrae.
Ah, so the joint surfaces themselves allow for the twist.
Exactly. This rotation is essential for many torso movements, like swinging a golf club or looking over your shoulder. But remember, the ribs themselves do act as a physical limit, dampening the total range. So it's the bony geometry that permits high potential rotation, even if the rib cage prevents the full expression of it.
Let's break down the typical thoracics versus the atypical ones. You mentioned T5, T8 are typical.
Yes, the typical vertebrae, T5 through T8, demonstrate all the characteristic features: perfectly heart-shaped body, demifacets, facets on the transverse processes, long sloping spinous process. T1 is the first major atypical point. Like C7, T1 has an almost horizontal long spinous process, often making it nearly as prominent as the vertebral prominence itself. Clinically, distinguishing between C7 and T1 by palpation can sometimes be tricky.
And its rib facets are different too.
Yes. Crucially, T1 has a complete costal facet superiorly for the head of the first rib, but only a demifacet inferiorly for the head of the second rib. Then T9 through T12 become atypical as they transition towards the lumbar region. They start to lose the facets on the transverse processes. They tend to have single complete costal facets on their bodies rather than demifacets, and their spinous processes become shorter and less sloped, more like lumbar vertebrae. They're preparing for the flexion-extension focus of the lower back.
Before we move fully down, let's quickly review the surface anatomy again. If I'm examining a patient, how do I find these thoracic structures?
Palpation is foundational. As we mentioned, C7, the vertebral prominence, is typically the first easily identifiable spinous process when the neck is flexed. If you feel inferiorly from C7, you'll usually encounter the long horizontal process of T1 next. The spinous processes of the other thoracic vertebrae follow in sequence downwards. Their tips, however, because of the steep slope, usually lie at the level of the vertebral body of the vertebra below. That's an important relationship to remember. The transverse processes of the thoracic vertebrae are often hard to feel distinctly because of the thick overlying back musculature, like the trapezius and rhomboids. But in leaner individuals, you might be able to palpate them laterally to the spinous processes. Clinically, knowing C7-T1 are the main landmarks up top is vital.
That brings us down to the lumbar vertebrae, L1 through L5. This is where the spine really takes on its ultimate weight-bearing role. The mobility-stability balance shifts almost entirely towards stability and compression resilience here.
Absolutely. The bodies here are characteristically massive, just huge. They are the largest in the entire mobile column. This vast surface area is necessary to distribute the enormous compressive loads exerted by the entire upper body, especially when you're standing, lifting, or carrying weight.
And the shape contributes to the lower back curve, right?
Yes. The collective wedge shape of the lumbar IV discs, thicker anteriorly than posteriorly, and the bodies themselves, creates that distinct inward curvature, the lumbar lordosis.
How does the articulation geometry change down here to handle that compression? We know axial rotation is heavily restricted in the lumbar spine.
The restriction comes directly from the orientation of the articular facets. For L1 through L4, the articular facets are generally sagittally oriented, meaning they face primarily medially and laterally, running almost front to back.
Okay, like they're interlocking.
Exactly. This configuration acts like a lock and key, fitting tightly together. It allows a tremendous range for flexion and extension bending, forward and backward, which is the main movement pattern of the lower back, but it effectively prohibits axial rotation. It's a structural design built for maximum mechanical stability under vertical load.
But then, right at the very bottom, L5S1, the geometry changes again. Why that final tweak in orientation?
L5S1 is a special case. It's subjected not only to massive compression, but also to significant shear forces. Think about the lumbosacral angle, the rather acute angle at which the lumbar spine meets the relatively fixed sacrum. There's a natural tendency for L5 to want to slide forward on S1.
Okay, so it needs extra protection against slipping forward.
Precisely. To handle this shear stress, the articular facets of L5S1 are uniquely oriented more coronally, more in the frontal plane. This coronal orientation helps resist that anterior slippage, or spondylolisthesis, of L5 on S1, while still facilitating the necessary flexion and extension movements for the pelvis and hips. It shows incredible specialization right at the terminal mobile segment.
And unlike the thoracic region, where transverse processes are key for rib articulation, the lumbar vertebrae feature some smaller, distinct processes specifically designed just for jib muscle attachments, right?
Yes, the large transverse processes are still present, of course, providing leverage for muscles like quadratus lumborum. But if you look closely, you'll find these smaller details. You have the accessory process, a small bump on the posterior aspect of the base of the transverse process. It serves as an attachment point for some of the deep intertransversory muscles.
Okay.
Then there's the more prominent mammillary process found on the posterior surface of the superior articular process. This process provides a crucial attachment point for some of the most important deep stabilizers of the lumbar spine, the powerful multifidus muscle and also some intertransversory muscles. These seemingly small bony anchors are vital for the fine-tuned segmental microstability of the lower back. Moving past the mobile segments now, we encounter the spine's rigid foundation, the sacrum and the coccyx.
The sacrum is truly a masterwork of fusion, isn't it? It's that single large triangular bone resulting from the fusion of the 5 sacral vertebrae, S1 through S5. It forms the solid, unmoving base of the vertebral column and connects the spine to the pelvis.
It does. And within that fused structure, we need to identify the internal and external features. Internally, the sacral canal is the continuation of the vertebral canal, running down the center. Critically, it doesn't contain the spinal cord itself, but rather the cauda equina, that bundle of lower lumbar, sacral, and coccygeal spinal nerve roots. Remember, the spinal cord typically ends around the L1, L2 vertebral level.
Right, just the nerve roots down there.
And anteriorly?
Anteriorly, the superior edge of the S1 body forms a sharp, prominent lip known as the sacral promontory. This is a key landmark, especially in pentrics for measuring pelvic dimensions. And on the anterior pelvic surface, you see 4 pairs of pelvic sacral foramina, where the anterior rami of the S1, S4 spinal nerves exit.
And externally on the back, we see the remnants of the processes that fuse together, forming ridges.
Yes, the posterior surface is much rougher and features 3 distinct longitudinal crests, marking where the embryonic processes fused. The central jagged line is the median sacral crest, which represents the fused spinous processes.
Lateral to that are the intermediate sacral crests, which are remnants of the fused articular processes. And further laterally still, you find the lateral sacral crests representing the fused transverse processes. You also see the posterior sacral foramina on this surface, where the posterior rami of the S1, S4 nerves exit.
And laterally, there's the surface that connects to the pelvis.
Yes, the large ear-shaped auricular surface, auricular meaning ear-like. This rough surface is crucial as it articulates with the corresponding auricular surface on the ilium of the pelvis to form the very strong, relatively immobile sacroiliac SI joint. This is the critical junction that transfers the weight of the entire axial skeleton head, trunk, upper limbs to the pelvic girdle, and then down to the lower limbs.
Inferior to that large sacrum, we have the small vestigial structure, the coccyx.
The coccyx, or tailbone, yes.
Yeah.
It's usually formed by the fusion of 4 rudimentary coccygeal vertebrae, C1 through C4, although the number can vary slightly, sometimes 3, sometimes 5. CO1 often remains separate from the others.
Does it have much function left?
Its function has been significantly minimized evolutionarily. It doesn't support weight when you're standing. However, it does flex interiorly slightly when you sit down and lean back, helping to bear some of the pressure then. More importantly, though, it provides essential attachment points for parts of the gluteus maximus muscle, the coccygeus muscle, part of the pelvic floor, and the anacoccygeal ligament, which supports the position of the anus and contributes to pelvic floor integrity.
So, still important for pelvic structures. Now, Palpating the lower back is often the first step in diagnosing back pain. What's the essential surface anatomy landmark for the clinician in the lumbar region?
That would absolutely be the L4 spinous process. Clinicians use a very reliable surface anatomy trick. You find the highest points of the two iliac crests, the top edges of your hip bones, and imagine a horizontal line connecting them. This line, often called the supracristal plane or Jacobi's line, reliably passes through the tip of the L4 spinous process, or sometimes the L4-L5 interspace.
And the reason we highlight L4 or that L4-L5 interspace as the key landmark is directly related to the safety of the spinal cord during procedures like a lumbar puncture, correct?
Exactly. Since the spinal cord proper typically terminates as the conus medullaris around the L1 or L2 vertebral level in adults, performing a puncture below L3, and usually at the L3-L4 or L4-L5 interspace, ensures that the needle enters the subarachnoid space well below the end of the cord.
So you're only encountering nerve roots.
Yes, the needle only encounters the fluid-filled meningeal space containing the relatively resilient mobile nerve roots of the cauda equina, which tend to get pushed aside rather than pierced. This makes the L4-L5 intervertebral space, just below the L4 spinous process identified by the iliac crests, the preferred and safest site for withdrawing cerebrospinal fluid, CSF, or administering spinal anesthesia without risking direct damage to the spinal cord itself.
Now, let's take that developmental step back we discussed earlier and appreciate the incredibly complex process of how these vertebrae form vertebral ossification. At birth, it's far from the fully developed fused structure we've been studying.
The developmental timeline is truly astonishing, yeah. At birth, a typical vertebra is still mostly cartilage. It only have 3 primary ossification centers, bony areas that have started forming. There's one in the centrum, which will eventually form the main mass of the vertebral body, and one in each half of the neural arch, which forms the posterior structures like the laminae and pedicles.
So 3 separate bony pieces held together by cartilage initially.
Exactly. These 3 bony parts are initially united by hyaline cartilage at the neurocentral joints.
So when do these first 3 centers begin to fuse and solidify the structure into a single vertebra?
It's a sequential process over several years. The 2 halves of the neural arch begin fusing posteriorly, usually in the midline, starting during the first year of life. Interestingly, this fusion process actually starts down in the lower weight-bearing lumbar region and proceeds upwards towards the cervical spine.
Okay, arches fuse first, then they connect to the body.
Right. Next, the now fused bony arches fuse with the centra, the body, at the neurocentral joints. This fusion starts earlier in the upper cervical region, around age 3, but it can take significantly lower down. It often doesn't fully complete in the lower lumbar region until after the 6th year of life, and failure of those neural arch halves to fuse properly posteriorly can result in developmental defects like spina bifida occulta, a hidden defect, or more severe forms, highlighting the clinical significance of this precise developmental timing.
And then later, during adolescence, the spine gets another upgrade with the appearance of secondary ossification centers.
Yes, 5 secondary ossification centers appear after puberty. There's one for the tip of the spinous process, one for the tip of each transverse process, and then crucially 2 for the vertebral body itself, the superior and inferior annular epiphyses, often called ring epiphyses.
The role of those annular or ring epiphyses is more than just adding structure, isn't it? They seem to have a direct impact on the intervertebral discs nearby.
They're absolutely critical interfaces, especially during growth. These are ring-shaped bony rims that cap the superior and inferior surfaces of the vertebral body, right at the periphery. Temporarily, before they fully fuse to the main body, they serve 3 vital functions.
Okay, what are those?
First, they act as growth zones, enabling the vertebral bodies to increase in height during adolescence. Second, they help protect the main body from excessive pressure. And third, perhaps most importantly, they remain cartilaginous for a while before fully ossifying and fusing. This cartilaginous nature makes them permeable.
Permeable for nutrients.
Yes, this permeability is essential for the diffusion of nutrients and fluid between the vascularized bone of the vertebral body and the largely avascular cartilage of the adjacent intervertebral disc, particularly the nucleus pulposus. They act like a conduit for disc health during growth.
And when does this complex multi-stage construction project finally finish? When does the spine become fully adult bone with everything fused?
Full solidification occurs when those superior and inferior annular epiphyses finally unite, or fuse, with the centrum, the main vertebral body. This process typically occurs in early adult life, usually completed around age 25. Once those final 5 secondary centers have completely fused, The vertebra has reached its adult size and structural integrity.
Moving from development to variation, the source points out that while the count of 7 vertebrae is nearly universally fixed, there's actually quite common variability in the total number of thoracic and lumbar vertebrae. This can significantly alter spinal mechanics for an individual.
That's true. This variability usually manifests as a sort of segmental shift, where one vertebra near the border of a region adopts the characteristics of the vertebrae in the neighboring region. We talk about a cranial shift when a segment takes on the features of the segment superior to it.
Okay, what are some practical examples of a cranial shift? How do we see that?
Well, the classic example mentioned is the presence of a cervical rib. This is an extra rib, usually small, attached to the C7 vertebra. Normally, C7 doesn't have a functional rib articulation, but in a cranial shift, it develops one, potentially giving the individual 13 pairs of ribs instead of the usual 12.
And that can cause problems.
It can be clinically relevant, yes. A cervical rib can sometimes compress the nerves of the brachial plexus or the subclavian artery as they pass between the neck and the upper limb, leading to thoracic outlet syndrome symptoms like pain, numbness, or vascular issues. Another example of cranial shift is sacralization of the L5 vertebra. This is where L5 is partially or completely fused or incorporated into the sacrum.
So it becomes part of the sacrum.
Effectively, yes. Functionally, this shortens the mobile lumbar spine from 5 vertebrae down to 4. This might potentially reduce stress at the L5-S1 level itself, but it could also transfer more load and stress to the adjacent L4-L5 segment above it.
And what does the opposite look like, a caudal shift?
A caudal shift means a segment adopts characteristics more typical of the segment inferior to it. This might be seen, for instance, as a small rudimentary lumbar rib forming on the L1 vertebra, giving it a more thoracic appearance. The more impactful example, though, is lumbarization of the S1 segment. This is where the first piece of the sacrum, S1, fails to fuse properly with the rest of the sacral bone, S2, S5. S1 essentially becomes a separate mobile vertebra.
So you'd effectively have 6 lumbar vertebrae instead of 5.
Exactly. You have an increased number of free, mobile lumbar vertebrae. Clinicians must always be aware of these common variations, sacralization and lumbarization, because they fundamentally change the biomechanics and the anatomical numbering of the segments, which is crucial for surgery or interpreting imaging.
Let's shift our focus now specifically to clinical issues highlighted in the text, starting with a very widespread problem affecting bone density, particularly in the elderly, vertebral body osteoporosis.
Yes, osteoporosis is the most common metabolic bone disease. It severely affects the microstructure and density of bone, making it weaker. The vertebral bodies, being primarily trabecular bone, are particularly susceptible, especially in postmenopausal women due to hormonal changes.
What happens to the vertebrae?
It results in brittle, demineralized bone tissue. The bone density is compromised, making the vertebrae much less able to withstand compressive forces. The clinical consequence is a greatly heightened susceptibility to impacted fractures, meaning the bodies essentially collapse or compress downwards.
Even from minor things.
Yes, often from minor trauma like a simple fall, or sometimes even just from the routine compressive forces of daily activities or coughing. These compression fractures, often wedge-shaped, contribute massively to chronic back pain, loss of height, and the characteristic forward-stooped posture, or kyphosis, dowager's hump, seen in severe cases.
Sometimes direct surgical intervention is required to relieve pressure on the nervous tissue within the vertebral canal. This brings us to the procedure known as laminectomy.
A laminectomy is the surgical excision or removal of the spinous process and the adjacent supporting laminae of one or more vertebrae. Sometimes the pedicles might be removed too in a vertebrectomy.
Why would that be done?
The primary goal is to open up the posterior side of the vertebral canal and gain access to its contents, or simply to relieve pressure on the spinal cord or exiting nerve roots. This pressure might be caused by various things: hypertrophic bone growth, like bony spurs or thickened ligaments, tumors growing within or pressing on the canal, or maybe a severely herniated intervertebral disc that's compressing neural structures.
Is it a risky procedure?
All surgery has risks, but since the spinal cord itself ends around L2, a laminectomy performed lower down in the lumbar region, say at L4, L5 to treat spinal stenosis, is generally considered relatively safe regarding the neural elements. It mainly involves carefully moving aside the nerve roots of the cauda equina to access the area needing decompression. Higher up, where the spinal cord is present, the risks are naturally greater.
Let's turn back to the cervical spine for a moment, where that trade-off for high mobility leads to some unique vulnerabilities, particularly regarding cervical dislocations.
That's right, because the articular facets in the cervical region are oriented relatively close to the horizontal plane. Remember, we described them earlier as being sort of stacked like shallow cups or plates. They are much less interlocked compared to the vertically oriented interlocking facets in the lumbar spine.
Meaning they can slip more easily.
It means they're more easily dislocated with less force than might be required to actually fracture the bone itself. A sudden flexion or twisting injury can cause one vertebra to slide forward on the one below it. Now, here's the critical detail mentioned in the text. Because the vertebral canal is relatively large in the cervical region compared to the diameter of the spinal cord, a slight dislocation or subluxation can sometimes occur without causing severe spinal cord damage. The cord has a bit more room to accommodate minor shifts.
But when does that luck run out? When does it become catastrophic?
The risk becomes extremely high, catastrophic even, if the injury is severe enough to cause the articular facets to jump or lock. This means the inferior articular facet of the superior vertebra slides completely anteriorly and locks in front of the superior articular facet of the inferior vertebra.
Oh, that sounds bad.
It is. In that situation, or in a full fracture dislocation where bone is broken as well, the spinal cord is very often severely compressed, stretched, or even transected, leading to paralysis or death. Furthermore, a very dangerous scenario can occur if a significant dislocation happens, but then spontaneously self-reduces, meaning the vertebrae slip back into apparent alignment on their own or with initial handling. The underlying life-threatening ligamentous damage to the discs and stabilizing ligaments might be missed on initial X-rays, masking a highly unstable spine. A full MRI is usually essential in suspected cases to assess ligament integrity.
Let's detail the two most infamous high cervical fractures mentioned in the clinical boxes, starting with the fracture of the atlas, the Jefferson fracture.
A Jefferson fracture is specifically a burst fracture of the C1 vertebra, the atlas ring. It typically results from a violent vertical compressive force transmitted down through the skull. Think of a severe blow to the top of the head or a head-first diving accident into shallow water.
What actually breaks?
The force is driven down through the occipital condyles onto the lateral masses of C1. These lateral masses are then driven forcefully outward, laterally. This outward displacement causes simultaneous breaks in both the anterior arch and the posterior arch of the C1 ring, usually in 2 places on each arch.
It sounds absolutely devastating, yet the text notes the spinal cord is often spared major injury. Why is that?
That is the crucial, somewhat counterintuitive point about a pure Jefferson fracture. Because the fragments of the lateral masses are driven outward, the overall diameter of the vertebral foramen, which houses the spinal cord at that level, actually widens slightly or stays the same. Therefore, provided the crucial surrounding ligaments, especially the transverse ligament of the atlas, which holds the dens of C2 in place, remain intact, the spinal cord may be spared from direct bony injury. The integrity of that transverse ligament is the key predictor of neurological outcome.
Okay, so the outward burst spares the cord. Now, the second notorious injury involves the axis, C2, the hangman's fracture.
This is technically known as traumatic spondylolisthesis of the axis. It's specifically a fracture that occurs through the pars interarticularis, or pedicles, of C2. Despite the historical name relating to judicial hangings, which caused a similar injury pattern through hyperextension and distraction, this fracture is now most commonly associated with severe hyperextension trauma to the head and neck, often from high-speed motor vehicle collisions where the head snaps back abruptly over the neck rest.
What happens in the fracture itself?
The fracture line runs through the bony struts, connecting the C2 body to its posterior elements, laminae facets. If this injury is only a simple, non-displaced fracture, it might actually be stable and heal well. However, in the most severe cases, often classified as type 3A or type 3 injuries in the Effendi or Levine classifications, the fracture through the pedicles is coupled with significant tearing of the C2-C3 intervertebral disc and, crucially, rupture of the strong anterior longitudinal ligament between C2 and C3.
And when that ligament and disc rupture along with the fracture, the result is often non-survival.
Yes, very often. When that entire anterior stabilizing structure fails, disc and ALL, the anterior segment of C2, the body and the dens, can displace significantly anteriorly relative to the C3 vertebra below, while the posterior elements of C2 remain attached to C3. The ensuing severe displacement, stretching, or complete severance of the spinal cord at this high level is usually incompatible with life. The failure of the anterior longitudinal ligament under extreme hyperextension tension here really underscores its critical role in limiting that backward motion, even though its considerable tensile strength can eventually be overcome by catastrophic forces.
Okay, let's shift our attention now from the bony structures themselves to the connections that hold them all together and allow movement. We should start with the joints connecting the vertebral bodies, which are classified as symphyses.
Right. The joints between adjacent vertebral bodies are symphyses, which are a type of secondary cartilaginous joint. This means the bony surfaces are covered by hyaline cartilage, but they are united by a pad or disc of fibrocartilage between them. They aren't designed for the wide-ranging, complex motion you see in synovial joints like the shoulder or hip. Instead, symphyses are built primarily for immense strength, resilience, weight-bearing, and allowing only slight movement between the bones. The entire structural integrity and continuity of the spinal column relies heavily on these joints.
And the defining feature of these vertebral symphyses, of course, are the intervertebral discs. They are the primary shock absorbers and pivots.
They are absolutely critical. The IV discs account for a significant portion of the spine's length, roughly 20–25% of the total height of the presacral vertebral column. They are the primary structures allowing movement between adjacent vertebrae, acting as pivot points. And yes, their dual structure, a tough outer ring and a gelatinous inner core, makes them uniquely suited to both distribute compressive loads and facilitate that movement.
Let's detail that structure more, starting with that outer retaining wall, the annulus fibrosus. What's it made of?
The annulus fibrosus is a very robust, multi-layered fibrous ring. It's made of concentric layers, or lamellae, of fibrocartilage. Think of it structurally like the layers of a radial tire. Within each layer, the collagen fibers run obliquely between the vertebrae, but the direction alternates in adjacent layers. This cross-hatched arrangement provides tremendous tensile strength to resist forces in multiple directions: compression, torsion, bending.
What are its main jobs?
Its role is essentially twofold. First, it forms a tough, fibrous retaining wall to contain the central nucleus pulposus under pressure. Second, it functions to securely bind the adjacent vertebral bodies together, contributing significantly to the stability of the joint. The source notes that its outermost fibers blend structurally with the anterior and posterior longitudinal ligaments, reinforcing the entire complex.
And inside that tough ring is the inner part, the gelatinous core, the nucleus pulposus.
This is the true shock absorber and pivot. The nucleus pulposus is the inner, semi-fluid gelatinous substance located slightly posterior to the center of the disc. It's the remnant of the embryonic notochord. It has a very high water content, especially in youth, around 80–90%.
And how does it work mechanically?
Because it's mostly water, it's essentially non-compressible under physiological loads. It acts like a hydraulic cushion or a ball bearing. When the spine moves or bears weight, the pressure exerted by the vertebral body above is transmitted hydrostatically through the nucleus pulposus in all directions. This allows the disc to change shape, deform, and distribute the load evenly across the entire surface of the vertebral end plates and outwards to the annulus fibrosus. This fluid core is what gives the spine its resilience and ability to absorb shock.
We mentioned earlier that the discs rely heavily on diffusion for nutrition, as they are largely avascular. Given that the spine relies on them for 80 years or more, how does that nutritional dependency change with age, and what are the consequences?
It's a really key factor in age-related disc degeneration. As we discussed, the nutrition is primarily mediated by diffusion across the vertebral end plates from the capillary beds in the adjacent vertebral bodies. This process is most efficient in youth when the end plates have some cartilaginous permeability, linked to the annular epiphyses before fusion. As we age, several things happen. The discs progressively lose their high water content, becoming dehydrated. The proteoglycan molecules that bind water break down. The end plates become less permeable. All this diminishes the ability of the disc to exchange nutrients and remove waste products,
Leading to degeneration.
Yes. The disc becomes less flexible, less resilient, and less effective as a shock absorber. It essentially dries out, hardens, and often shrinks in height. This degenerative cascade contributes significantly to the overall height loss seen in older adults and makes the disc more prone to tears and herniation.
We also have those peculiar small joints found only in the neck that are often misclassified, the uncovered tebral joints, sometimes called the joints of Luschka.
Ah, yes, the uncovered tebral joints. These are found exclusively in the cervical spine, generally between the C3 and C7 vertebrae. They are formed between the superiorly projecting unstenoid processes, those raised lips on the sides of the superior surface of the vertebral body we mentioned earlier, and the beveled infralateral surfaces of the vertebral body immediately above.
Are they true joints?
Well, they're often described as small synovial joints by some, but others consider them degenerative spaces or clefts that form over time within the disc. The source text implies they might not be true synovial joints. Regardless of their exact classification, clinically they're incredibly significant because they are primary sites for degenerative changes in the cervical spine. The source explicitly highlights that these uncovertebral regions are very prone to osteophyte formation, the development of bony spurs due to chronic irritation or degeneration. Because of their location right next to the intervertebral foramen, these osteophytes frequently impinge directly on the nearby exiting cervical spinal nerves, or even the vertebral artery, leading to neck pain, radicular arm pain, or numbness, cervical spondylosis.
Now for the essential stabilizing cables that run the entire length of the spine connecting the bodies, the longitudinal ligaments. We have the massive anterior longitudinal ligament, ALL, covering the front.
The ALL is a very broad, thick, powerful band of fibrous tissue. It runs the entire length of the vertebral column, attached firmly to the anterior surfaces of the vertebral bodies and the intervertebral discs, from the pelvic surface of the sacrum right up to the base of the skull, where it continues as the anterior atlanto-occipital membrane.
What's its main function?
Because it is so broad and inherently strong, its primary mechanical role is to vigorously limit extension of the vertebral column. It's the body's main defense against excessive backward bending or hyperextension injuries. When we see those catastrophic extension injuries like the severe stages of the hangman's fracture, it is precisely this ligament, along with the anterior annulus, that has been subjected to and failed under extreme tensile forces. It also helps maintain the stability of the IV discs anteriorly.
And its counterpart, running on the inside of the vertebral canal, is the posterior longitudinal ligament, PL.
The PLL runs inside the vertebral canal, attached to the posterior surfaces of the vertebral bodies and discs, essentially forming the anterior boundary of the spinal canal itself. Its primary function is the opposite of the AL. It helps to limit excessive flexion of the vertebral column, preventing hyperflexion. It also helps prevent posterior herniation of the nucleus pulposus.
But it's not as strong as the AL, is it?
No, and this is a critical point. The PLL is significantly narrower and inherently weaker than the AL, especially over the vertebral bodies. It broadens somewhat over the discs, but it's still thinnest and weakest in the lumbar region.
And that relative weakness, especially in the posterolateral corners, helps explain the most common pattern of disc herniation, doesn't it?
Absolutely. Because the PLL is narrowest over the central posterior aspect of the bodies and discs, it leaves the posterior corners, posterolateral aspects, of the discs relatively unprotected and unsupported. When the nucleus pulposus herniates due to excessive pressure, often from flexion combined with lifting, it almost always pushes out in a posterolateral direction into the space where the PLL offers the least resistance.
And that's right where the spinal nerves are exiting.
Precisely. The herniated nucleus material exits the confines of the annulus and PLL and immediately impinges on the traversing or exiting spinal nerve roots within the intervertebral foramen or lateral recess, causing sciatica or other radicular symptoms. It's important to note, too, that the PLL continues superiorly from C2 up to the skull, becoming broader and stronger, where it's known as the tectorial membrane. This membrane attaches firmly to the internal floor of the cranial cavity, specifically the clevis, providing crucial stability to the craniocervical junction.
Beyond the symphysis between the bodies, we have the joints between the vertebral arches, the synovial joints that truly dictate the type and range of motion possible in each region, the zygapophyseal or facet joints.
Exactly. These are classified as plain synovial joints. They are situated between the inferior articular processes of the vertebra above and the superior articular processes of the vertebra below. And we must reiterate their specific orientation in space, near horizontal in the cervical, near vertical coronal, and the thoracic, near vertical sagittal in the lumbar, except L5S1, which is more coronal, is the primary physical mechanism that controls the trade-off between stability and mobility region by region. They guide and limit movement.
And like other synovial joints, they have cartilage and a capsule.
Yes, the articular surfaces are covered by smooth hyaline cartilage, and each joint is enclosed by a thin, fairly loose fibrous joint capsule. Because they are synovial joints with capsules containing nerve endings, they are inherently pain-sensitive structures and a common source of chronic back and neck pain, especially when they become arthritic.
What's particularly fascinating here and clinically vital is the specific nerve supply to these small facet joints. This is where Hilton's law comes into play, leading to a somewhat complex innervation pattern.
Hilton's law, in general, states that the nerve supplying a joint also supplies the muscles moving that joint and the skin overlying the joint. The specific application here dictates a very precise and clinically important, somewhat redundant innervation pattern for the zygapophyseal joints. Each facet joint receives its nerve supply from the medial branches of the posterior rami of two adjacent spinal nerves. Specifically, it's innervated by the medial branch from the posterior ramus at the same level. AD, the medial branch from the posterior ramus of the spinal nerve immediately superior to that level.
Why the redundancy? Why innervation from two different spinal nerve levels for one small joint?
Well, redundancy is often a protective mechanism in biology. In this context, it likely ensures the joint maintains sensory feedback, proprioception and nociception, even if one of the supplying nerve branches is injured or compromised. But for clinicians treating chronic facet joint pain, which, as I said, can be a massive source of axial back or neck pain, it creates a specific therapeutic challenge.
Meaning, if a practitioner is performing a pain-blocking procedure like a medial branch block, diagnostic, or radiofrequency denervation, therapeutic rhizolysis, targeting a specific painful facet joint, they absolutely must target both of those contributing medial branches.
Precisely. If they only block or ablate the medial ramus at the level of the joint itself, but fail to also target the medial ramus from the level above, the joint will likely remain partially innervated by the surviving branch, and the patient's pain relief will be incomplete or short-lived. Understanding and correctly applying this dual innervation requirement is an absolute cornerstone of modern, targeted interventional pain management for face-to-genic spine pain.
Okay, next we look at the accessory ligaments of the vertebral arches, the crucial stabilizing elements that supplement the joints and run between the arches. The ligamenta flava, yellow ligaments, are especially interesting because of their high elasticity.
Yes, the ligamenta flava connect the adjacent laminae, running vertically between them and forming part of the posterior wall of the vertebral canal. They are quite unique in the entire body because they contain a massive amount of elastin fibers, up to 80% elastic tissue by dry weight, which gives them their distinctive yellow color in fresh specimens. Flavum means yellow.
What functional advantage does all that elasticity provide? Why aren't they just strong collagenous ligaments?
That high elasticity is incredibly vital to normal spinal mechanics. Firstly, it allows them to stretch significantly during flexion and then recoil. This helps to resist sudden, excessive separation of the laminae during acute flexion, thus acting like a brake and protecting the underlying intervertebral discs from excessive posterior bulgier compression. But perhaps more subtly, because they are constantly under some degree of tension, even in the neutral position, they actively assist the intrinsic back muscles in maintaining normal upright posture. And critically, they use stored elastic potential energy to help smoothly return the vertebral column to the extended position after a flexed movement. They are essentially passive, energy-storing extensors of the spine, reducing the muscular effort needed for posture and movement.
We also have the ligaments connecting the spinous processes, the interspinous and supraspinous ligaments.
Right. The interspinous ligaments are relatively thin, almost membranous sheets that connect the adjacent spinous processes from root to tip. They are considered fairly weak. Running superficial to them, connecting just the tips of the spinous processes, are the supraspinous ligaments. These form a much stronger cord-like band running from the C7 spinous process all the way down to the sacrum. Both the interspinous and supraspinous ligaments primarily function to limit excessive flexion.
However, in the cervical region, these posterior ligaments undergo a major transformation, right? They are replaced by the much more substantial neutral ligament.
Exactly. In the neck, the supraspinous and interspinous ligaments are replaced by, or rather expand into, the neutral ligament, ligamentum nuchae. This is a strong, broad, triangular, median fibrous sheet that extends in the sagittal plane from the external occipital protuberance and crest on the skull down to the spinous process of C7.
Why such a big ligament in the neck?
It's necessary because the cervical spinous processes, especially C3, C5, are short and often bifid, providing less direct attachment area for the powerful posterior neck muscles. The neutral ligament essentially serves as a large midline fascial plane, providing extensive attachment points for muscles like the trapezius and splenius capita cervicis. It also helps to passively support the head and resist excessive forward flexion.
Let's conclude our discussion today with a clinical synthesis, focusing on the very common problem of back pain. The source outlines 5 specific categories of structures in the back that receive innervation and can therefore be potential sources of pain. This seems vital for pinpointing a diagnosis.
Yes, understanding the anatomy of pain perception in the back is crucial. The 5 categories of innervated structures that can cause pain are: 1. Fibroskeletal structures. This includes the periosteum, covering the vertebrae, the ligaments, especially the highly innervated posterior longitudinal ligament, and importantly, the outer perimeter fibers of the annuli fibrosi of the AV discs. 2. The meninges. These are the coverings of the spinal cord and nerve roots. Dura mater, arachnoid mater. They're supplied by small recurrent meningeal branches, vertebral nerves, and can be a source of pain, often described as deep or aching. 3. The synovial joints. Primarily, this refers to the capsules of the zygapophyseal facet joints, which we've discussed are richly innervated. 4. The muscles. The intrinsic deep muscles of the back themselves, supplied by the posterior rami. Pain here is often due to strain, spasm, or ischemia. 5. The nervous tissue itself. Direct compression or irritation of spinal nerves or nerve roots causes referred pain, like sciatica, perceived in the distribution of that nerve, dermatome, myotome, sclerotome.
If the pain is localized, meaning it's felt primarily right in the back itself, rather than radiating down a limb, where is it typically originating from among those sources?
Localized back pain, often called axial pain, is generally traced back to several potential sources. It could be muscular, arising from spasm, strain, or ischemia in the intrinsic back muscles. Or it could be related to the synovial joints, typically due to inflammation or osteoarthritis of the facet joints, facet syndrome. Acute localized pain that arises suddenly, perhaps after lifting something improperly and is associated with a disc problem, is usually attributed not to the nucleus pulposus itself, which is largely annular, but rather to the acute tearing of the innervated outer fibers of the annulus fibrosus, or perhaps due to the pressure of the torn disc material directly irritating the highly sensitive posterior longitudinal ligament.
And finally, let's bring in the aging factor one last time. How does chronic mechanical stress over decades change the joints and discs, ultimately leading to conditions that cause chronic pain?
Well, as the IV discs age, degenerate, and lose their fluid content and height, their ability to distribute pressure evenly across the end plates decreases significantly. This leads to increased and often abnormal chronic compressive forces being concentrated at the periphery of the vertebral bodies, and particularly on the facet joints. In response to this altered, increased mechanical stress, the body attempts to stabilize the degenerating segment. It does this partly by forming osteophytes, which are bony spurs or outgrowths, around the margins of the vertebral bodies, especially near the disc, and along the articular margins and capsular attachments of the facet joints. This is essentially reactive bone formation and attempt at reinforcement.
And if those bony spurs form specifically around the zygapophyseal facet joints, they can compromise the space where the spinal nerves are trying to exit the vertebral column.
Exactly. The zygapophyseal joints are located immediately adjacent to the intervertebral foramina. When osteophytes develop around these facet joints due to arthritis, they can significantly narrow the space within the foramen, spinal stenosis, or the lateral recess, directly impinging upon or irritating the emerging spinal nerves. This nerve impingement results in the classic pattern of pain radiating down the limb along the nerve's path, referred pain along the nerve's dermatome, the area of skin it supplies. It often also causes involuntary protective muscle spasm or even weakness in the muscles supplied by that nerve root, the associated myotome. This anatomical chain reaction degenerative facet joint changes, leading to osteophyte formation, leading to nerve root impingement, leading to dermatomal myotomal symptoms, is the critical pathoanatomical link that informs diagnosis and all targeted treatment procedures, from physical therapy to injections to surgery. We have certainly concluded a very demanding but I think fascinating study today. We've mapped the incredibly diverse bony specializations that define that crucial trade-off between mobility and stability across the cervical, thoracic, and lumbar regions. We followed the incredible process of vertebral ossification from cartilage to adult bone. And we've anchored this entire column with a deep understanding of its resilient symphysis, its movement dictating synovial joints, and the ligaments holding it all together.
Precisely. We journeyed from the delicate, specialized pivot of C1 and C2, designed for head movement, down to the massive weight-bearing capacity required of the lumbar vertebrae. And we saw how those complex joints and ligaments, like the remarkably elastic ligamenta flava, the stabilizing longitudinal ligaments, and the critically important two-nerve innervation pattern of the facet joints, dictate not only how we move, but also, unfortunately, the common mechanisms behind spinal pain.
Next time, we shift our focus more from the static structure to the dynamic function of the back. We'll explore the specific movements possible at the vertebral column, examine the various layers of deep and superficial muscles that produce these movements, and then delve into the vital contents housed within the protective vertebral canal, focusing particularly on the complex structure of the spinal cord itself, its meningeal coverings, and the organization of spinal nerve roots.
Before we go, here's something to think about based on today's discussion. We talked about anatomical variations, particularly lumbarization, where the S1 segment fails to fuse with the sacrum, effectively giving an individual 6 mobile lumbar vertebrae instead of the usual 5. Now, we also established that the L5S1 joint is already inherently prone to high anterior shear forces because of the steep lumbosacral angle, requiring that special coronal orientation of its facets for stability. So the question is, what does adding an extra mobile segment right above the sacrum due to lumbarization actually do to the long-term shear stability and the compressive load distribution across the entire lower lumbar spine and the SI joints? Does having that extra bit of mobility low down ultimately increase the risk of instability, spondylolisthesis, or earlier degeneration at the levels below and above it? It really makes you ponder whether more mobility in certain areas is always a good thing biomechanically, something to mull over until our next deep dive. Thanks for listening to Bookfulness.